Let's study gout. Gout is an inflammatory disease caused by deposition of monosodium urate and monohydrate crystals in and around synovial joint, leading to recurrent attacks of acute synovitis. So gout is an inflammatory disease. It is due to the deposition of the monosodium urate and the monohydrate crystals in the synovial joints, due to which recurrent attacks of acute synovitis occurs. And the prevalence of the gout is 1 to 10 per 1000 person. It more commonly occurs in the male, and the ratio of male is to female is 20 is to 1. The classification of the gout. Primary gout and the secondary gout. Primary gout may be due to under excretion of the uric acid or overproduction of the uric acid. And in secondary gout, the primary disease is the acquired disease like myeloproliferative disease, drugs, renal failure, and the secondary disease is the gout due to prolonged hyperuricemia. Causes of gout. Gout is due to diminished renal excretion or due to increased production of the uric acid. Why did uric acid excretion is decreased? If there is renal failure, if there is lead toxicity, if there is increase in renal tubular reabsorption, if there is lactic acidosis, if there is history of drug intake, if the patient is taking drugs like thiazide, loop diuretics, aspirin, cyclosporin, and the pyrazinamide. This causes the diminished renal excretion. The overproduction of the uric acid is due to myeloproliferative and lymphoproliferative disease, psoriasis, high fructose intake, and the glycogen storage disease if the patient is on chemotherapy, hemolysis if the patient has inherited disorder like Lesch-Nance syndrome, in which there is hypoxanthine guanine phosphoribosyl transferase mutation, phosphoribosyl pyrophosphate synthetase 1 mutation, and if there is high intake of red meat, seafood, and the offal. So there are mainly the three causes: due to overproduction of the uric acid, due to reduced excretion of the uric acid, and there is high intake of red meat, seafood, and the offal. The clinical features. The typical patient of the gout is male, which is more than 30 years, which is obese, which is fond of alcohol, and hypertensive. We can remember that the patient of the gout is mainly the young male, more than 30 years, with gun. G for gout, and also G for it mainly occurs in the great toe. U for there is hyperuricemia, and N for there is needle-shaped crystal or it is negatively birefringent. When the fluid of the synovial fluid is seen under the polarized microscopy, it moves towards the left, due to which it is negatively birefringent, and the crystals forms are needle-shaped. Uricemia, negatively birefringent, and needle-shaped crystals. The acute presentation of the gout are: the patient presents with joint pain, and the pain is of sudden onset and it is very severe, which is the worst pain ever of the patient, which makes the patient wake early in the morning. The patient is so severe that the patient is unable to wear socks, and the joint pain is self-limiting and it recovers in 1 to 2 weeks, but the joint pain is precipitated by minor local trauma, exercise, or if the patient drinks alcohol. On examining, the skin is red, shiny, swollen, hot, and tender, which is similar to cellulitis and septic arthritis. Gout typically affects the metatarsophalangeal joint, the big toe, which is the great toe, in 70% of the patients. Other joints are also involved like ankle, fingers, olecranon bursa. Sometimes more than one joints may be involved. And after an acute attack, there is desquamation of overlying skin. In chronic gout, there is recurrent acute attacks, which is polyarticular involvement of more than one joints. And due to recurrent acute attacks, there is joint erosion, which causes chronic pain, stiffness, and deformity of the joint. In chronic gout, there is formation of the large tophi, which may ulcerate through the skin and form the discharge and helps in the formation of granuloma. So granuloma is formed due to large tophi. In chronic gout, the patient may present with uric acid stones due to interstitial nephritis, especially in which the patients are taking diuretics. The investigations of the gout. As in this serum uric acid are increased, so we need to see the serum uric acid. It may or may not be increased in acute cases, but it is increased in chronic cases. Normal value of uric acid, serum uric acid in male is less than 0.42 millimole per liter, and in female it is less than 0.35 millimole per liter. After taking the sample of the synovial fluid and seeing it on polarized microscopy, it will move towards the left, which is due to which it is negative birefringent urate crystal, which is needle shaped. On X-ray, in acute gout, we can see soft tissue swelling. This is the soft tissue swelling. And in chronic gout, there is narrowing of the joint space due to and secondary osteoarthritis, and there is formation of the erosion, which is called tophi, which is called punched out cysts erosions in para-articular bone ends. Here you can see the narrowed joint. This is the erosion, which is called tophi, punched out cyst. This is the soft tissue swelling. And the other investigations are 24-hour urinary uric acid excretion on low purine diet. ESR and CRP is increased as it is inflammatory condition, so increase in acute condition. Renal function test, lipid profile, and complete blood count. For the management of the acute attack, we can advise rest, ice pack, and give the non-steroidal anti-inflammatory drugs like indomethacin and naproxen. Paracetamol is not given because paracetamol do not have anti-inflammatory action. Aspirin is also not given because aspirin causes hyperuricemia, and in gout there is already hyperuricemia. And if the patient cannot tolerate NSAID, then we can give non-steroidal anti-inflammatory drugs. Then we can give steroidal anti-inflammatory drug, which is corticosteroid, but it has many side effects. So we give it intra-articular triamcinolone. So we give colchicine, which is very effective drug. If the patient is not relieving after giving colchicine, then the patient do not have gout. It is very effective drug, but it is not the drug of choice because it causes diarrhea and myopathy. Interval therapy in between the acute gouts. Non-pharmacological treatment. If the patient is obese, we advise for the to lose weight and decrease or avoid alcohol intake. Avoid diuretics, especially thiazides, and avoid red meat and seafoods. Pharmacological management. The indications of pharmacological management are that if the gout is recurrent more than one per year, if there is presence of tophi, if there is damage to the bone and the joint, if there is renal impairment or nephrolithiasis, if there is high uric acid level. So what drugs we do give? We give uricosurics. Uricosurics means uric acid in the urine. So it increases the excretion of the uric acid, so inhibit reabsorption of the uric acid. And the drugs are probenecid, sulfenpyrazine, and lesinurad. In lesinurad there is IN, increase urage, increase uric acid, increase excretion of lesinurad. IN is increase excretion, increase excretion of uric acid. We can also give allopurinol, which is the xanthine oxidase inhibitor. From the purine, xanthine is formed, and from xanthine, uric acid is formed by the xanthine oxidase enzyme. And allopurinol inhibits this xanthine oxidase enzyme. So we can give allopurinol. And febuxostat, this is the XO, xanthine oxidase stat, keeps the xanthine oxidase static, means decrease xanthine oxidase level, so decrease the formation of the uric acid. And after uric acid, there is formation of allantoin, which is water soluble by the enzyme uricase, but this process is not found in human beings. This is only found in birds. So we can also give the uricase enzyme, and the drugs containing uricase enzyme are the rasburicase and pegloticase. And as the rasburicase is the short acting, pegloticase drug is made. Polyethylene glycol is added in the uricase. This is called pegloticase. We give these drugs when there is resistant tophi, and after giving this uricase, this uric acid is converted into allantoin, which is water soluble, and it is excreted in the urine. Uricosurics and allopurinol should not be used only if acute attack completely subsides, and it is given with NSAID or colchicine for 3 to 6 months. Uricosurics and allopurinol is not given when there is acute attack. After It is only given after acute attack subsides, because this is the joint and the uric acid is coming in. This is the blood. This is the tissue. These uricosuric drugs and the allopurinol decreases the uric acid level. So when the uric acid level is decreased in the blood, the uric acid from the tissue, there is disturbance of concentration gradient, due to which the uric acid from the tissue comes out and try to maintain the gradient, but during acute attack there is increased permeability of the joint, so the uric acid can enter the joint. So after the acute attack subsides, there is decrease in permeability of the joint. After that, we can give uricosurics and allopurinol. We can also do surgery like curettage if the tophi has ulcerated and has failed to heal with conservative treatment. And after curettage, wound is left open and dressing applied until it heals. This is all about gout, and you can find these notes on the links below on the Telegram. Thank you.